The chapter we are learning today is Chapter 20, the infections of the respiratory tract. My name is Ava Falahi, and I will be presenting a Spanish flu case story, the anatomy of the respiratory tract, the upper respiratory viral infections, and then a common cold case study. I will be focusing on Chapter 20, Section 1. These are the chapter objectives, and this presentation will include each. The pandemic of 1918, also known as the Spanish flu, was thought to begin with 18 cases in early March in Kansas, and spread to European civilians and soldiers who were fighting in the Great War, otherwise known as World War I, by May 1918. It was the summer of 1918, and 20-year-old Floyd, that's him right here, a U.S. Army private stationed in Kansas, began to feel ill. He visited the camp doctor complaining of a cough, a headache, and some chills. Within a day, Floyd's fever reached 40 degrees Celsius, which is 104 degrees Fahrenheit. He became incoherent and lost consciousness. When Floyd awoke, he found himself in a large barracks, lying on a cot among a long line of cots filled with 6 soldiers. His cough was severe. Floyd saw dark purplish-brown spots appear on the face of the GI lying on the cot next to his. The soldier began to cough blood, and eventually his face turned blue from lack of oxygen, a sign that death was imminent. Doctors could do little to help. There's Floyd right there. Fortunately, after about 2 weeks, Floyd started to improve. Yay! Celebrating! Go Floyd! Many others were not so lucky and died. No one knew what caused the disease raging through the camp or how to stop it. This is a public health poster in 1918 warning that flu can develop into what we now know as secondary bacterial pneumonia. No effective treatment was known at the time. These are the section objectives for the first section of Chapter 20. Lung and upper respiratory tract infections are among the most common human diseases. Many different viruses, bacteria, fungi, and parasites can cause pneumonia. Successful lung pathogens come equipped with attachment mechanisms and countermeasures against various lung defenses, such as alveolar macrophages. The most prevalent respiratory diseases are of viral origin, and most viral infections of the respiratory tract rarely spread beyond the lung. These typically resolve within 2 weeks. Respiratory tract infections are classified by whether they affect the upper or lower respiratory tract. The upper respiratory tract includes the upper airways, consisting of nasal passages, oral cavity, pharynx, and larynx. Other structures in the head that have direct or indirect communication with the upper airways include the passages to the sinuses, where all the small air-filled cavities in the skull, lacrimal ducts or tear ducts, and the middle ear. The lowest structure in the upper respiratory tract is the larynx, the voice box, right here. Oral and nasal cavities open into the pharynx, forming the upper part of the human respiratory tract. The pharynx is the hollow space shared by the nasal and oral cavities, right here. Both the esophagus, the tube that carries the food from the mouth to the stomach, and the trachea, or the windpipe, which is part of the lower respiratory tract, are continuous with the pharynx. Different portions of the pharynx are named for the structure closest to them. The nasopharynx, for example, right here, is the part of the pharynx attached to and adjacent to the nose. Inflammation of the pharynx is a common respiratory problem called pharyngitis, or sore throat. The uvula is an extension, right here, of the soft palate that plays a role in producing some sounds. The epiglottis covers the trachea, the windpipe, when we swallow, and prevents food and saliva from going down the trachea, right here. After it is swallowed, food moves down the esophagus to reach the stomach. Lower respiratory tract. The lower respiratory tract consists of a series of diverging tubes that eventually terminate in alveoli, small sacs where oxygen from the inhaled air is exchanged for carbon dioxide in the blood in a process called respiration. The tubes leading to the alveoli include the trachea, right and left main bronchi, bronchioles, terminal bronchioles, and alveolar ducts. Some people assign the trachea as being part of the upper respiratory tract. All the respiratory tubes are warm and moist and remove impurities from inhaled air as it travels to the alveoli. The lungs and tubes that conduct the air into the lungs, trachea, left and right bronchi, constitute the lower respiratory tract. Human lungs are divided into separate segments called lobes. The inhaled air travels down the trachea and main bronchi and through the dividing bronchioles and terminal bronchioles until it reaches the location where respiration, where respiration occurs, the alveolar ducts and alveoli. The cells that line the interior of the respiratory tubes, the lumen, are epithelial cells, which have moving appendages called cilia that are extensions of the cellular membrane. Cilia removes foreign particles, including microorganisms trapped in the sticky mucus. Mucus is formed when mucin combines with water. Mucin is secreted by goblet cells and is among the epithelial cells. Here are the goblet cells, here's the cilia. Goblet cells secrete mucin that combines with water to create sticky mucus. The cilia move like a whip, upward moving the mucus and its trapped particles up toward the oral and nasal cavities for clearance and expulsion. Sneezing is an example of this expulsion. The ciliated epithelium, referred to as the mucociliary escalator, works to keep the lungs devoid of microorganisms. Any impairment of the mucociliary, escalator results in the accumulation of inhaled particles in the airways and a reflexive cough. For example, people who heavily smoke will cough a lot when they wake up because their ciliated epithelium is trying to clear their lungs of the debris. Smokers will stop the coughing with their first smoke of the day because the nicotine in the cigarette smoke paralyzes the cilia and stops the mucociliary escalator. This paralysis of the cilia can leave the person more susceptible to diseases. These are the 20.2 section objectives. Another case history. Jacob, a rambunctious 5-year-old boy, right here, brought to the clinic by his mother, was complaining of a scratchy sore throat, a non-productive cough, which is a cough that does not produce sputum, rhinorrhea, which is a runny nose, nasal congestion, a stopped-up nose, and a headache that started the night before. He did not have a fever. His complete blood count, CBC, the number of platelets and red and white blood cells in blood, along with its differential, the different types of red and white blood cells, was normal, as was his chest x-ray. Jacob was diagnosed with the common cold and advised to rest, drink plenty of clear liquids, and use over-the-counter cough suppressants and either ibuprofen or acetaminophen for pain. Yay! Jacob survived! There he is, all happy. That is all from me, and now on to the viral infections of the respiratory tract.
Hi, my name is Jamie DiMatteo. I will be covering section 20.2. I'll be going over the viral infections of the lower respiratory tract. I'll also be going over RSV, which is respiratory syncytial virus, and I'll also be going over influenza, which is also known as the flu. One of the most frequently occurring viral infections is known as the common cold. The common cold contains over 200 viral subtypes. And over on the right, there's a chart from the book, kind of explaining what the common cold is, its symptoms, how you can get the common cold, treatment, and also prevention. Rhinoviruses are one of the most common viral subtype to cause the common cold. There are over 100 subtypes of it. What are the complications of the common cold? There are no really known complications other than minor inflammation, sneezing, coughing, and all of these can be treated with over-the-counter medication. The economy spends about $17 billion per year buying over-the-counter medication. Children can catch as many as 8 colds in 1 year, and adults can catch up to 5. The second viral infection of the respiratory tract that I will be covering is viral sinusitis. This is inflammation in the sinuses. It's caused by infection of upper respiratory tract airways. Why does viral sinusitis occur? Well, mucous membranes in sinus cavities become inflamed when infected with a virus, which impede the flow of mucus, causing a buildup of congestion. What are the complications of sinusitis? These range from having a headache from the buildup of mucus, also can cause bacterial sinusitis and middle ear infections due to congestion and poor drainage, which provide a breeding ground for bacteria. And this is further discussed in section 20.3. The main lower respiratory tract viral infection that I'm covering is the respiratory syncytial virus, also known as RSV. RSV occurs when adjacent infected cells fuse into a syncytium, which is a giant cell that contains many nuclei. RSV can be classified as enveloped, negative sense. It's a single-stranded RNA. So how is RSV contracted? You can get RSV from person to person. It primarily affects infants. You can get infected if the virus comes into contact with eyes, mouth, nose, really through droplets. The CDC recommends immunization. RSV is the most common cause of bronchiolitis, which is the inflammation of the bronchioles, and it also is the most common cause of pneumonia among infants and children younger than 1 year. Influenza is the next lower respiratory tract infection. Influenza, or also known as the flu, is a single-stranded, negative sense, enveloped RNA. There are 3 different types of the flu. So we have type A, type B, and type C. So all of these types are based on antigenic determinants. And starting with type A is the cause of epidemics. It can infect animals and people, and it is constantly changing, which is why there are different flu vaccines every year. The next type is type B. Type B does not cause pandemics. It's found primarily in humans, and it has a milder illness. The next is type C. Type C does not cause epidemics or pandemics, and it causes only mild disease. There's a chart on the right-hand side of the presentation which kind of shows how the flu is split into categories based on its subtypes, lineages, clades, and subclades. And then underneath that chart is a picture of the influenza virus with different parts of it, which I will get into on the next slide. The pathogenicity of the flu influenza is dependent on 3 different proteins. The first protein being hemagglutinin. This is a transmembrane protein that forms the spikes on the viral surface, which is shown in the bottom right corner is a picture of hemagglutinin zoomed in. It's a zoomed in picture of the cell that was on the previous slide. Hemagglutinin also binds to N-acetylnorminic, also known as sialic acid, on the surface of respiratory cells to gain entry. And on the bottom left-hand side is a picture depicting how this happens. The other 2 proteins that the pathogenicity of the flu rely on is number 2 is neuraminidase, and number 3 is M2. Neuraminidase is on the surface, which releases budding viruses from the host cell. It also prevents the viruses from clumping together. The third protein, M2, releases a viral genome into host cell cytoplasm, which is depicted, both of these proteins are depicted on this picture. The neuraminidase is on the top, it's the pink one, and M2 is on the bottom, and it's depicted as an M2 ion channel, and it's purple. The small genetic changes that occur in influenza viruses over time usually produce viruses that are closely related to one another, which can be illustrated by their location close together on a phylogenetic tree. And on the right-hand side is a picture depicting the phylogenetic tree from the CDC. It shows how certain strands and strains of the influenza virus share a common ancestor, how they are then further divided into the subclades. There are 2 ways that these genetic changes can occur. They can occur through the antigenic shift, which is the process of RNA segment mixing. This begins with 8 RNA segments of each flu genome, and they uncoat, mix together in the cytoplasm, and then they resort to form a new influenza virus containing a form of the hemagglutinin gene. The second way that these genetic changes can occur is through the antigenic drift, which are just smaller mutations in the HA and NA genes of the influenza virus.
Hi, my name is Olivia Kenny, and I will be presenting on COVID-19, croup, and the universal flu shot. Up first, we have COVID-19, which is a lower respiratory tract viral infection. COVID-19 is a highly transmittable disease caused by a severe acute respiratory syndrome, coronavirus 2, which is single-stranded positive sense enveloped RNA virus of the Coronaviridae family. Up until 2003, the common cold was the only coronavirus disease that affected humans. However, in December 2019, a new coronavirus emerged in Wuhan, China, causing COVID-19. The World Health Organization declared it a pandemic on March 11, 2020, where there were 118,000 cases in 110 countries, including the U.S. People who are most at risk are adults over 60 years, immunosuppressed patients, people with diabetes, and people with underlying diseases of the heart and lungs. Here are the symptoms of COVID-19. COVID-19 usually starts with flu-like symptoms, such as a dry cough, fever, and shortness of breath. In other cases, it could cause bluish lips, onset confusion, and troubled breathing. Most cases are asymptomatic, so the actual mortality rate is still being determined. COVID-19 can be spread when an infected person breathes out droplets and tiny particles that contain the virus. Other people can then breathe in these droplets, or they can land on others' eyes, nose, or mouth. For pathogenesis, SARS-CoV-2 primarily infects the respiratory system. It gains entry into the host cells via the ACE2 receptor. Once inside, it replicates and triggers an inflammatory response that can lead to acute respiratory and stress syndrome. The virulence factors include the spike protein binding to the ACE2 receptor, allowing viral entry. The nucleocapsid protein plays a role in viral replication and immune system evasion, and in severe cases, a cytokine storm, which is an excessive immune response damaging the lungs and other tissues. This can lead to pneumonia in both lungs, requiring the use of a ventilator and even organ failure. To diagnose COVID-19, a PCR test is required to amplify viral RNA from a nasal or oropharyngeal swab. Treatment of this disease are corticosteroids and antivirals like remdesivir and Paxlovid. However, supportive care remains the primary treatment. To prevent COVID-19, stay up to date with the vaccines, practice good hygiene by washing your hands thoroughly, and when infected, take precautions to prevent spread by wearing a mask and distancing yourself. Next up, we have another lower respiratory tract viral infection named croup, or laryngotracheobronchitis. Croup is usually caused by parainfluenza, especially types 1 and 2. The same virus that causes bronchitis in adults can cause croup in children. Croup is most common in young children, between the ages of 6 months and 5 years old. Symptoms of croup include a fever, runny nose, and with the main symptom being the barking cough, which is caused by the swelling of the larynx. Croup is spread through close contact with an infected person's respiratory secretions, such as when they cough, sneeze, or talk. It can also be transmitted by touching surfaces or objects contaminated with the virus and then touching the mouth, nose, or eyes. For pathogenesis, parainfluenza virus enters the body primarily through the respiratory tract, infecting key areas like the larynx, trachea, and bronchi. Once the virus gains entry into the host cells, it begins to replicate. This replication process triggers an immune response. As the virus continues to replicate, the inflammation worsens, causing swelling and narrowing of the airways. The airway obstruction results in one of the symptoms, being the barking cough. Croup is typically diagnosed based on a child's clinical symptoms, with confirmation sometimes supported by a physical examination or viral testing. Treatment for croup depends on the severity of the symptoms. Mild cases can be treated at home with humidified air and steroids to reduce airway inflammation. More severe cases may require hospitalization and oxygen therapy. Croup can be prevented by practicing good hygiene, such as hand washing, avoiding close contact with infected individuals, and disinfecting comically touched surfaces. Also, teaching your child to cover their coughs can help reduce the spread of the virus. Lastly, we have the search for a universal flu shot. Each year we get vaccinated against the influenza virus because the virus can change or mutate just enough to evade our body's immune defenses. This constant chain makes it necessary to update the flu vaccine annually to ensure its effectiveness against the current strand. There are several advantages to having a universal flu shot. First, it can free us from the fear of getting the flu. Second, it helps to reduce the overall cost of the flu vaccines by minimizing the spread of the virus, which lowers the demand for more expensive treatments or hospitalizations. Lastly, widespread vaccination plays a key role in decreasing flu-associated deaths and healthcare costs. Why do the current flu vaccines need to be modified regularly? The primary challenge in combating the influenza virus lies in a protein called hemagglutinin, which is located on the outer surface of the virus. Hemagglutinin acts like a key that allows the virus to enter human cells, but it's constantly changing or mutating, making it difficult for our immune system to respond to it year after year. Visually, hemagglutinin looks like a series of lollipops anchored to the viral coat, with the head of each lollipop striking out. Most current flu vaccines are designed to target the head of these hemagglutinin proteins, as it is the part that is most highly exposed to the immune system. However, this part of the protein is also highly mutable, meaning it changes frequently. On the other hand, the stalk of the hemagglutinin protein is less mutable, but the stalk is hidden from our immune system by the larger, more prominent head. This makes it a much harder target for vaccines. Here are different approaches to a universal flu shot. Scientists at the National Institute of Allergy and Infectious Disease are working on a universal flu vaccine by exploring different approaches to target the influenza virus more effectively. One promising method involves using nanoparticles, which are tiny microscopic pieces of the HA protein stem. These nanoparticles can stimulate the immune system to recognize and fight the virus. Another strategy focuses on virus-like particles. These are molecules that mimic the influenza virus and target an immune response, but they don't have the ability to replicate or cause illness. Additionally, scientists are experimenting with DNA-based vaccines. This approach offers a way to directly target the virus's genetic blueprint and may help create a more lasting immunity. Lastly, another approach involves creating antigenic peptide sequences for many different strains of the flu viruses. These peptides are small fragments of the virus that can be used to help the immune system recognize a wide variety of flu strains, making the vaccine more universal. An added benefit of these studies is that antibodies made in a lab by studying any of these four approaches could potentially be effective in treating people with the flu. Another approach is targeting internal viral proteins. Internal viral proteins, such as the influenza nucleoprotein, mutate less frequently than the surface proteins. Because of this ability, antibodies targeting the internal nucleoprotein could offer a more consistent and long-lasting defense against the flu. The influenza nucleoprotein is a crucial component of the virus's structure, and it is typically stripped off from the viral nucleic acid when the virus infects a cell. Once removed, it is displayed on the surface of infected cells, making it a potential target for the immune system. Antibodies specifically targeting this nucleoprotein can help recognize and bind to infected cells, signaling further destruction of cytotoxic T cells. These T cells are responsible for killing infected cells. By eliminating infected cells more efficiently, targeting the influenza nucleoprotein could reduce the severity of the disease, leading to milder symptoms and potentially a faster recovery. Another potential strategy are antibodies targeting the internal protein M2 of the influenza virus. Although M2 is mostly hidden inside the viral envelope, a portion of the protein is exposed on the outside of the virus. This exposed part is immunogenic, meaning it can trigger an immune response, and it is also genetically stable, making it a target for a vaccine that could provide broader protection across different flu strands. Because the exposed portion of M2 doesn't mutate as frequently as other surface proteins, it could be a key component in a universal vaccine. However, there is a challenge. A hybrid virus, such as the swine flu, could potentially escape antibodies raised against the human M2 protein. This is because certain viral strands may have slight differences in the M2 protein, preventing the immune system from recognizing them effectively. This highlights the need for further research to ensure that targeting M2 can provide broad protection against all influenza strands.
These are the section objectives for 20.3. Case history: a big pain in a little ear. Chloe is a 2-year-old, generally healthy child who was brought to the clinic by her father. The child had a fever since the previous night, was irritable, and kept pulling on her left ear. Chloe also had a runny nose for the past 2 weeks. Her temperature was 38.5 degrees Celsius, or 101 degrees Fahrenheit, at the clinic, and the physical exam showed a red and swollen ear, an erythematous reddened ear canal, and a bulging tympanic membrane. Chloe was diagnosed with acute otitis media and prescribed an antibiotic that she had to take for 7 days.
Hello, I'm Penelope Loper, and I will be talking about upper respiratory tract bacterial infections, specifically otitis media, bacterial sinusitis, case history 20.3, pharyngitis, and streptococcal sequelae. Acute otitis media, also known as middle ear infection, occurs when bacteria gets trapped in the middle of the ear. Otitis media can be caused by gram-negative bacteria, gram-positive bacteria, and viruses. As we see in the picture showing a healthy tympanic membrane, which is the eardrum, it is not red and almost transparent. Below that is a picture of a tympanic membrane infected with otitis media, which causes redness and inflammation to the eardrum. Otitis media is common in infants and toddlers because their eustachian tube is shorter and almost horizontal, which makes drainage more difficult, leading to bacteria getting trapped. The image to the right shows how infants' eustachian tube is only angled at 10 degrees. Shown in the image to the right, as we age, the eustachian tube lengthens and its path becomes angled at about 45 degrees, making drainage of the middle ear much easier and ear infections less likely. There are 3 bacterial species that are the most frequent causes of otitis media in normal, healthy children. Those 3 species are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella cathartus. A multivalent polysaccharide vaccine protects against Streptococcus pneumoniae, which is the leading cause. The image to the right shows streptococci under the microscope. Moving on to bacterial sinusitis. Bacterial sinusitis is inflammation and congestion of the paranasal sinuses caused by bacterial infection that obstructs the sinuses and mucus flow. The accumulation of mucus in a warm and relatively airy cavity supplies bacterial pathogens with a nice breeding ground. It often accompanies middle ear infection in children and pneumonia in adults. Symptoms of bacterial sinusitis include pressure behind the eyes, pain in the face, foul-smelling nasal discharge or breath. The usual course of treatment for bacterial sinusitis is antibiotics. This image from the CDC shows healthy paranasal sinuses compared to paranasal sinuses infected with bacterial sinusitis. As we can see, the infected sinuses are filled with mucus, and the tissue surrounding the sinuses is red and inflamed. Here we have a case study about a high school football player with Group A streptococcus. This case study will introduce pharyngitis before we get into the details. So, Dalen, a 16-year-old high school athlete, came to the clinic complaining of a sore throat. He did not have a cough or any cold or flu symptoms, and his cervical nodes, which are the lymph nodes in the neck, were enlarged and tender to palpitation. There was exudate visible on his tonsils and pharynx, and his temperature was 39.8 degrees Celsius, which translates to 103 degrees Fahrenheit. The physician assistant told Dalen that he probably had strep throat, but she could not perform a rapid strep test to confirm because they had run out of strips. The PA then swabbed the back of Dalen's throat and sent the sample to the lab for culture and antibiotic sensitivity testing. Dalen was given an antibiotic empirically, which is before the diagnosis was confirmed. He was told that he was contagious and should rest and avoid contact with others until better. He followed the recommendations, recovered, and was back playing football in a few days. The lab isolated Streptococcus pyogenes, also called Group A Streptococcus, which is abbreviated as GAS. Pharyngitis, also known as a sore throat, is inflammation of the pharynx and is primarily caused by viruses, such as the common cold and flu. It can also be caused by multiple bacteria, such as gram-positive, gram-negative, and mycobacteria. The most common bacterial cause of pharyngitis is Streptococcus group A. Streptococcal pharyngitis, also known as strep throat, is caused by Streptococcus pyogenes infection. It is very contagious and spread through person-to-person contact and indirect contact with items contaminated by secretions. Symptoms include sudden onset of high fever and sore throat, tender enlarged cervical lymph nodes, exudate on tonsils, and absence of a cough. Strep throat is treated with antibiotics. In the image to the right shows the mouth of someone with strep throat. Notice the redness on the pharynx and the enlarged tonsils. Some strains of streptococcal pyogenes produce exotoxins known as streptococcal pyogenic exotoxins, SPEs. These exotoxins can cause fever and a red rash called scarlet fever, shown in the bottom image. The rash starts on the head and neck, then spreads to the trunk, then to the arms and legs. Another symptom of SPEs is a very distinct red bumpy tongue referred to as strawberry tongue, which is shown in the top image. There are rapid strep tests to diagnose strep throat in the doctor's office when you come in. The rapid strep test is used to detect Streptococcus pyogenes in a patient's throat. It works by combining extracted antigens from a throat swab with red-tagged antibodies specific to group A strep. If the strep antigen is present, it binds to the antibody, and the complex moves to a membrane with additional anti-strep antibodies, forming a visible red line indicating a positive result. A blue control line confirms correct reagent addition. A positive result, however, does not confirm an active infection, as some individuals carry strep bacteria without symptoms. The tests are highly specific for Streptococcus pyogenes. Now we will talk about streptococcal sequelae, which are conditions and complications that occur after a streptococcal infection. They are caused by the immune response to the bacteria. Antibodies cross-react with the host cells in an autoimmune reaction, resulting in serious sequelae. Some streptococcal sequelae include acute rheumatic fever, abbreviated ARF, and glomerulonephritis, which is a kidney disease. ARF is common in young children from ages 4 to 9. Symptoms of ARF include high fever, damage to heart, joints, skin, or nervous system, cross-reactive antibodies.
I'm Natalia,
T-cells,
and what I'm going to be presenting
complements.
is some case history, such as the bullneck case study, reemerging upper respiratory tract infections, such as diphtheria,
whooping cough, and some incidences. So starting with the bull neck case study, a mother rushed her 3-year-old girl into the hospital in New Mexico. They recently moved a week ago from El Salvador, and the little girl was not vaccinated. Her symptoms were a high fever of 104 degrees Fahrenheit. She was lethargic and she had difficulty breathing. The physical exam findings were she had swollen cervical lymph nodes, which gave her the bull neck appearance like we see in this image over here. And she had a grayish membranous growth at the back of her throat. And when the doctor scraped at it, she had bleeding. So when they did swab the back of her throat, they took it into the lab and they confirmed that it was diphtheria, which is caused by Corynebacterium diphtheriae. And so their medical response was immediate admission to the hospital. They treated her with penicillin and diphtheria-specific antitoxin. So the diagnosis confirmation was Corynebacterium diphtheriae. After being treated, she did improve within 10 days, and she was referred to a pediatrician for vaccination updates. So overall, the key takeaway from this case study is how important it is for children to get routine vaccinations to prevent diseases like diphtheria. So a little bit about diphtheria. The cause is the bacteria Corynebacterium diphtheriae, which is a gram-positive rod bacteria. So this bacteria was actually nearly eliminated through vaccination, but it's still a risk with global travel because, as we saw, not all vaccines are available to every country. And this is a reportable disease which requires notification to health authorities. And the different forms of this bacteria is toxigenic, which is lysogenized. It produces diphtheria toxin, which inhibits protein synthesis and causes systematic effects. The second form is non-toxigenic, which is non-lysogenized, and it does not produce toxin but can still infect the respiratory tract and skin, as we see in these images. Symptoms, treatment, and prevention. So upper respiratory infection symptoms include sore throat, low-grade fever, swollen lymph nodes, and a formation of a grayish pseudomembrane at the throat, which we also see in these images. Systematic effects. Toxin can cause heart and nerve issues such as cardiac dilation, arrhythmia, and even paralysis. The treatment is a combination of antibiotics and diphtheria antitoxin. The best way to prevent this is through the vaccine, which is inactivated diphtheria toxin included in the DTaP vaccine series. The importance of this vaccination is it's critical to prevent reemergence of diphtheria globally. Now we are going to move on to whooping cough. So the causative agent is Bordetella pertussis, which is a gram-negative bacillus. It is transmitted through inhaling aerosol droplets from an infected person, and the incubation period is 7 to 21 days. The stages of disease progression are 1, catarrhal phase, which is the initial symptoms similar to an upper respiratory infection. The second stage is paroxysmal phase, severe rapid coughing fits followed by a whooping sound on deep breaths. We saw a recording of this whooping sound in class when we went over the chapter 18, and you even stop breathing for a good minute, so it's very scary. The third stage is convalescent phase, which is gradual reduction of coughing episodes over 2 to 3 weeks as recovery begins. So this is a very highly infectious disease, especially during the early stages. So over here we have a picture of Bordetella binding to ciliated epithelial cells. So what Bordetella pertussis first does is it colonizes tracheal epithelial cells and adheres to their cilia. Then this adherence and the resulting damage impedes the mucociliary escalator that normally removes bacteria from the lungs. And we also see the bacteria have been pseudo-colored green in this image here. So over here we have a diagram of reported pertussis incidences by age group from 1990 to 2017. The incidence rate is per 100,000. So here in the beginning, in the early 1990s, parents started to refuse to vaccinate their children because of some studies that came out linking vaccination to autism. However, this has been scientifically rejected, and we see how towards the end in 2017, the incidences did drastically decrease.
Lower respiratory tract bacterial infections. In this section, I'm going to be covering bronchitis, community-acquired pneumonia, aka CAP, as well as case history 20.5, which covers strep pneumonia, and last but not least, atypical pneumonia. Lower respiratory tract bacterial infections. 1. Bronchitis. Bronchitis is the inflammation of the bronchi. Bronchi are large air passages that connect the trachea, also known as the windpipe, to the lungs and allow air to move in and out of the lungs. Bronchitis can either be acute or self-limiting. Acute bronchitis, which is very common, usually results from an infection and may be contagious. Most people recover after a few days or weeks. Chronic bronchitis, on the other hand, is defined as lasting at least 3 months and returning at least 2 years in a row. A productive cough is generally the only presenting symptom of bronchitis, and the bacteria that cause bronchitis include Bordetella pertussis, Mycoplasma pneumonia, and Chlamydia pneumonia. There are also multiple viral and bacterial etiologies. Community-acquired pneumonia is pneumonia acquired outside of a hospital, usually within a community setting. Some symptoms include confusion, especially amongst older people, excess sweating and clammy skin, loss of appetite, fatigue, low energy, headache, malaise, which is just not feeling well, or a sharp or stabbing chest pain that worsens when coughing or taking deep breaths. CAP, community-acquired pneumonia, is usually treated with antibiotics taken orally for a span of typically 5 to 7 days. Most people start feeling better within the first few days of starting the treatment, and for those who need to be hospitalized, antibiotics specific to the infection are given, sometimes intravenously. And atypical pneumonias affect multiple organ systems, usually produce a normal white blood count, and produce symptoms that appear gradually, which mimic upper respiratory infections at the onset of the infection. Community-acquired pneumonia is caused by organisms such as Mycoplasma pneumoniae, Legionella, and Chlamydophila. The most common cause of typical pneumonia are organisms such as Streptococcus pneumoniae. And the risk of contracting community-acquired pneumonia increases with age. This is because aging can weaken the lungs' ability to fight off microbes, and it can also lead to other conditions that can increase the individual's risk of CAP, and this infection is most common during winter months. In this data diagram over here, we can see that the
leading causes for lower respiratory tract bacterial infections include Streptococcus pneumoniae, Chlamydophila pneumoniae, and other viruses. Case history: night sweats in a nursing home. So this case history covers James, who in March was an 80-year-old resident of a New Jersey nursing home, had a fever accompanied by a productive cough with brown sputum. James reported to the attending physician that he was short of breath, had pain on the right side of his chest, and suffered from night sweats. Blood tests revealed that his white blood cell count was 14,000, which is a little bit above the normal count, which ranged from 4,500 to 10,000, composed of 77% segmented forms of polymorphonuclear leukocytes, and the normal value is a range between 40 to 60%, so this value is also about 17 to 37% above the normal count, which is quite alarming, and 20% bands, which are the immature PMNs, which was probably the most significant change one of the most significant changes in percent-wise, since the normal value is 0 to 3%. The chest radiograph revealed a right upper lobe infiltrate, and from this information, the clinician made a diagnosis of pneumonia. Microscopic examination of the patient's sputum revealed gram-positive cocci surrounded by a capsule in pairs and short chains. Bacteriological culture of his sputum and blood yielded that the specific bacteria found within this sample was Streptococcus pneumoniae, which, as we saw in the data model earlier, was the number one leading cause of lower respiratory bacterial infections. So Streptococcus pneumoniae occurs mostly among elderly, smokers, and immunocompromised individuals such as alcoholics and diabetics. There are 91 serotypes of Streptococcus pneumoniae that frequently colonize our airways. Humans are the only natural reservoir, making the host range for this natural reservoir narrow. And pneumococcal polysaccharide vaccine, PPSV, protects against 23 of more than 90 of the most prevalent polysaccharide types. Atypical pneumonia, the most common bacteria that causes this type of pneumonia is called Mycoplasma pneumoniae and is contagious and can spread from person to person. Mycoplasma lack a rigid cell wall and usually exist in filamentous form. They are the smallest known species of bacteria, and symptoms caused by this specific bacteria include headache, malaise, which is not feeling well, progression to a non-productive cough, possible low-grade fever, and chills.
Okay, I'm Charlotte, and I'm going to be talking about diseases of the upper respiratory tract as well, specifically Legionellosis, hospital-acquired pneumonia, tuberculosis, and pneumonia caused by select agents. Okay, in this slide we're talking about Legionellosis, which is commonly referred to as Legionnaire's disease. So it is caused by a gram-negative bacteria that causes an atypical pneumonia. We refer to this as Legionellosis pneumonia. This bacteria contaminates water sources. Inhaling the contaminated water is how the bacteria will spread. It is an intracellular pathogen growing inside alveolar macrophages and free-living amoeba. Some signs and symptoms that you have gotten this bacteria is fever, chest pain, coughing up blood-tinged sputum, muscle pain, abdominal pain, vomiting, and diarrhea. Some diagnosis, how you diagnose this Legionnaire's disease is it's actually quite difficult. You have to detect and measure the presence of the antibodies of the bacteria. So they're going to culture and grow the bacteria in a buffer culture yeast extract, which is like how they measure or how they grow the bacteria. And then they're going to use the enzyme immunoassay to detect and measure the presence of the antibodies. And if you do have the presence of the Legionnaire's disease, you would be treated with antibiotics, and those would be either macrolides or quinolones. Okay, so hospital-acquired pneumonia is a hospital-acquired infection, and a hospital-acquired infection is infections that patients will get when they are receiving healthcare for something that they already went to the hospital for, and then they get an infection while they're at the hospital. And then the most common form of the hospital-acquired pneumonia is Pseudomonas aeruginosa, which is a cause of burn infections. And Pseudomonas aeruginosa is a opportunistic gram-negative pathogen with a large aerosol arsenal of virulence factors, which contributes to mortality, specifically in patients with cystic fibrosis. So, hospital-acquired pneumonia caused by the Pseudomonas aeruginosa colonizes in the lungs for a long time, which leads to chronic infection, and that can form biofilm in the lungs of cystic fibrosis patients, reducing lung function, and that can lead to respiratory failure. So, some signs and symptoms of a Pseudomonas aeruginosa is cough, fever, shortness of breath, and chest pain, and it is commonly transmitted through water droplets and instruments. And then usually the treatment that they recommend is a 2-drug combination. There are other negative agents that cause gram-negative agents that cause hospital-acquired pneumonia, and a few of them are listed. But there's also a few gram-positive agents that are also associated with hospital-acquired pneumonia, and that is Staphylococcus aureus and streptococcus species. There's a few of the gram-positive ones. Okay, so this slide we're talking about tuberculosis, and then tuberculosis is often referred to as just TB. The causative agent of tuberculosis is an acid-fast bacillus, Mycobacterium tuberculosis. So in 1885, the HIV pandemic was happening, and they found that tuberculosis was growing, specifically in 1991 a strand they called multi-drug resistant tuberculosis, and that was increasing in and being fatal in patients who had been infected with HIV, and it was also infected to people who didn't have HIV and were just healthy, and it was contagious to both individuals. So, one way that we test for tuberculosis is a tuberculosis skin test, which indicates exposure to tuberculosis bacilli when it's positive. Um, so the acid-fast bacteria, um, Mycobacterium tuberculosis, the bacteria have a gram-positive cell wall, but they can't be gram stained because 60% of their cell wall is a lipid, and that's why we use the acid fast stain instead of like a gram stain. So when the immune system is exposed to Mycobacterium tuberculosis, it generates a T cell mediated response, which was why we did the skin test. But the Manto tuberculation skin test indicates a delayed type hypersensitivity reaction to tuberculosis proteins. And then the preferred method for TB screening for people who may not return for their skin test is the interferon gamma release assay, and also if they haven't received their vaccine, that's another way for that to test. And the skin test and the gamma release assay do not distinguish between the latent form of tuberculosis and the active form, which we'll talk about in the next slide. And then um, tuber- tubercles, which are granulomas, they're infected nodules that form around the site of infection, and they can develop into serious lesions that have a cheese-like consistency and can calcify into gone complexes, which we'll see a picture of that in the next slide. But it does spread from person to person. So, like in the little image from the CDC here, it just shows a reminder that it's spread through aerosolization of respiratory secretions of the tuberculosis bacteria. Okay, and so this is just an up close image of the calcifying gone complex of tuberculosis. And the left image, the arrows pointing to the gone complex on the right upper lobe of the patient's lung. And then on the right side is the, like you can see the cavity of that kind of like rectangular shape that they're pointing to. And they show the tuberculosis cavities have that like cheese-like calcified consistency. Okay, so then we're talking about the latent tuberculosis and active tuberculosis. So latent tuberculosis is if the trapped bacilli are not killed by the immune system, then the immune system contains it for a long period of time, but you're not going to be contagious and you're not infectious to other people. And then active tuberculosis, you're going to have symptoms and you are contagious. So the symptoms can be cough, eventually coughing blood, fever, loss of appetite, night sweats, weight loss, and fatigue. And the image to the right shows just a little bit more in detail of the bacterium entering the lungs and how it can 90% of the time will be like a latent form or the immune system gets the infection, but usually less than 10% of the time, it'll be a progressive primary tuberculosis, which is like the active form. And it continues growing, causing active disease. And then children and immunocompromised people are more susceptible to the active form of tuberculosis. And then secondary TB occurs in people who are immunocompromised, and it is serious because it causes severe cough, greenish or bloody sputum, low grade fever, night sweats, and weight loss. And the treatment is just going to depend on patient specifics, and usually they'll start with an initial simultaneous 4-drug therapy. And then there's another form, which is extensively drug resistant tuberculosis, which is like how it sounds. This type is resistant to 3 or more of the second line drugs and to the first line. So they'll start you on a couple, like when you have the treatment, they'll start you on first line and sometimes second line drugs. And if in this strain, there is more, you're like drug resistant to the first line and the second line drugs, which unfortunately means it's almost untreatable. Okay, so this is pneumonia caused by select agents, and bioterrorism is the intentional release of biological agents that bring about disease or death to humans, livestock, or crops, which is commonly talked about when we're talking about Bacillus anthracis, which is anthrax, and it's a spore forming gram positive rod that primarily causes infection in animals. The spores can survive decades in the soil, and under proper conditions, they can germinate and multiply. So the lethality of the bacteria is due to a 3-subunit toxin. The subunit protective antigen helps the trivalent toxin enter the host cell, and then the other 2 subunits, edema factor and lethal factor, attack the internal host metabolic components to disrupt host cell function and growth. And then some symptoms that usually starts off as like common cold symptoms, which then progress to fever, muscle aches, weakness, shortness of breath, and it can lead to additional symptoms like coughing up blood, shortness of breath, chest pain, and nausea. And then infections in humans usually result from like accidental exposure from like infected animals or animal products that have contaminated with the spores. But the transmission does not usually occur person to person, but the inhalation of anthrax has a prodromal phase that can last up to 5 days. And then once anthrax is suspected, rapid diagnosis and treatment is crucial for survival because death can occur within 48 hours. And then the treatments can be cisprofloxacin and doxycycline are common antibiotics that can be used to treat um, when you're exposed to anthrax. And then to the right is someone working in a lab and dealing with anthrax, and also to the right is the spores from the CDC website is a like close up microscopic image of the Bacillus anthracis.
Hi, my name is Gabby Novelli, and today I'm going to be presenting on sections F, I, and II of the fungal and parasite infections of the respiratory tract. Some of the things that we are going to cover today is identifying the most common causes of fungal lower respiratory tract infections, describing the difference between fungal and bacterial lower respiratory tract infections, and naming the risk factors associated with fungal respiratory tract infections. We're also going to go over a case study, which you can follow along in the textbook of chapter 20.6, which is page 643, and we are going to name all of and go over the most common names of all of them. Fungal and parasite infections, immunosuppression, and environmental exposures are the two most important risk factors associated with acquiring a fungal lung infection. Listed below are the most common causes of fungal lung infection, and we're going to go over every single one of them later in the presentation, so I'm going to save that. Now, the differences in fungal and bacterial lower respiratory tract infections is that fungal infections of the respiratory tract present with a consultation of vague and sometimes seemingly unrelated symptoms. Differences are also shown in how it's diagnosed, clinical presentations, and etc. Okay, now we're going to go over and examine a case study, 20.6, which can be found on page 643 of the textbook. A boxer's fight to survive. So Terrell is a 35-year-old male boxer who installs home insulation for a living, who was recently admitted to a Maryland hospital when he was presented at the emergency department, complaining of difficulty of walking, fever, chills, night sweats, and a recent of 21 pounds of weight loss, which is a significant amount. He denied having prior pneumonia, sinus infections, arthritis, blood in the urine, numbness, or muscle weakness. Tara also denied any history of intravasive drug use and reported to be in a monogamous relationship for the past 4 years. Going based off of that, there was no history of travel outside the area for the past year. A review of Terrell's past medical history showed that he had visited the emergency department 6 months prior with flu-like symptoms, a chronic cough that produced blood-tinged white spectrum, shortness of breath, loss of appetite, and weight loss. 1 month prior to current admission, he developed some painless subcutaneous nodules and became so short of breath that he could no longer continue boxing. So some tests were done at the time. An x-ray taken in the emergency department showed right upper lobe infiltrate, indicating pneumonia. A tuberculous skin test was negative.
and he was given a prescription for the antibiotic azithromycin, which is a common use antibiotic to treat bacterial infections of the respiratory tract and discharge. The cough and weight loss continued. The right picture on top is a picture of his lungs, which indicates that infiltration is in both the right and left lungs. As you can see, it's like cloudy, and that should not be there. A physical exam at the time of the current admission revealed several painful subcutaneous nodules, one filled with pus, and a tender tibia that prevented him from walking. A CDC obtained that at the time of the current admissions showed normal counts and differential. And the picture right above the picture of the lungs shows a mistake leg lesion at the tibia, which is mentioned. In Terrell's case, the expression of the frankly prolute material, which is the pus, from the left leg nodule suggests an infectious process. His recent history of chronic cough suggests that the infection in his patient probably started in the lungs, after which the organism disseminated throughout the body via the bloodstream. Fungus is a probable cause given the chronic nature of the patient's symptoms. Tuberculosis caused by the bacterium Mycobacterium tuberculosis also causes a chronic lung infection and might have been suspected except for the negative TB skin test. Okay, so now I'm going to go over fungal and parasite infections of the respiratory tract, what some of them are, what they're known for, and how it also relates to the case study. So to start off, we're going to do, I'm sorry if I butcher the name of all these. So first we're going to start off with coccidioidosis, also called valley fever. The fungus is endemic in the southwestern United States, and as mentioned in the case study, Terrell has never traveled to the western United States, so ruling out the exposure to coccidioidosis. The next one is histoplasmosis caused by Histoplasma capsulatum, which is a dysmorphic fungus, meaning it exits in two different forms depending on growth temperature. It lives as a mold with a filamentous form in solid, which is about 25 degrees Celsius, and changes its form to a small budding yeast once it enters a human's lung at 37 degrees Celsius. In the United States, it is found mostly in Ohio and Mississippi River valleys. It is most commonly presents a flu-like phlegmal illness, which is a tender red bump under the skin, and arthritis, which is swollen joints, and joint pain, none at which Terrell had, so it could not be that either. Okay, so down below are the last two fungal and parasite infections of the respiratory tract. Blastomycosis can disseminate to the lungs, skin, bone, and genitourinary tract, which is consistent with the pattern of organ involvement seen in this patient. Blastomycosis is endemic to eastern U.S. Cryptococcus neoformis, which is an encapsulate yeast that causes cryptoptychosis. Therefore, that could be considered. Cryptococcus, however, is in aged patients, although disease can also involve the skin, lungs, prostate gland, urinary tract, eyes, bones, and joints. Cryptococcus, therefore, was considered but rejected for Terrell. Amphotericin B, which is an antifungal agent, was ultimately given to Terrell, which caused his fever to be lowered almost immediately and skin nodules diminished. After 2 weeks, a fungus was found in the cultures of the nodule biopsy, the bronchial behavior lavage, and urine. This fungus was identified by a DNA probe, which determined that the diagnosis was from blastomycosis. Thank God Terrell was okay at the end and everything was fine, and it just took a very lengthy process and a long time for it to carry out to be determined what it actually was. And that is all for my part of the presentation, and thank you.
My name is Libby Peterson, and I am presenting on the summary of the respiratory system. So, respiratory tract infections today. Some main points: respiratory diseases have resulted in major changes in our behavior and shifts in population dynamics. There's been viruses like the SARS virus, the MERS virus, and the SARS-CoV-2 virus, and air travel and globalization became big ways of spreading deadly diseases. The infectious virus SARS showed the world how quickly an infectious agent could spread. It was the cause of a severe respiratory illness in Asia. It spread very rapidly around the world and caused 8,098 cases of the disease and resulted in 774 deaths around the world. Global interventions by health officials prevented a pandemic, but this virus showed how easy it was to spread viruses through international travel. After the outbreak of MERS and Ebola, the risk of a pandemic occurring was inevitable. In late 2019, COVID-19 emerged. COVID-19 quickly spread from China to the rest of the world, which turned into a historic pandemic. When another virus arises like COVID-19, it is going to be crucial to have coordinated global response to outbreaks so we can prevent the re-emergence of diseases and contain new diseases that will emerge. Portals of entry for respiratory tract infections are the eye, the colon, and skin. And a portal of entry is just an opening where the pathogen may enter. So many respiratory infections enter through the eye, and they're viruses that cause common cold. And some examples are, as you can see in the picture, are RSV, influenza viruses, parainfluenza, SARS, MERS, and COVID-19, Bacillus anthracis, Bordetella pertussis, and many more. Through the colon, it's RSV, and through the skin, it's Coccidioides species. So next is the portal's exit for the respiratory tract, and it is simply just out through your nose, the respiratory tract. So viruses that exit through here are viruses like the common cold, RSV, influenza virus, parainfluenza, like I said before, SARS, MERS, COVID-19, Bacillus anthracis, and all those other ones. And the port of exit is just how the pathogen exits or leaves the reservoir. Microbes that infect the respiratory tract, and these are just the viruses. In this chart, you can see the virus, the genome that causes them, and the disease that it causes. So first off, I'm going to describe each of the viruses, just an overview of what each of them are. So adenovirus, it causes the common cold. It's common and typically causes mild cold or flu-like symptoms, causes illness in all ages. Respiratory syncytial virus, it causes RSV disease. Common respiratory virus that causes mild cold-like symptoms. Infants and older adults are more likely to develop severe RSV and need hospitalization. Next is metapneumovirus. It causes the common cold and can cause respiratory disease, spreads from person to person or surface to person. Next is the influenza virus. It causes influenza and is a contagious respiratory illness caused by influenza viruses and can cause mild to severe illness. Parainfluenza viruses can cause croup or the common cold. Signs and symptoms are similar to the common cold. Most people recover on their own. Next is rhinoviruses. They cause the common cold. Most infections are mild, but they can cause serious illness in high-risk populations. No vaccine, treatment, or medicine to prevent this illness. Enteroviruses, the disease it causes is the common cold. It's common and usually affects infants, children, and teenagers, and most people experience a mild illness with symptoms like common cold, but some can have serious complications. Next is coronavirus. It causes the common cold, SARS, MERS, and COVID-19. Symptoms include runny nose, headache, cough, sore throat, and fever, usually spread from an infected person to other people. Moving on. Continuing with the microbes that infect the respiratory tract, but this time we're talking about bacteria instead of viruses. So we're talking about bacteria morphology, which is the study of the form, structure, and configuration of an organism, including parasites, and then the disease that the bacteria causes. So Mycobacterium tuberculosis causes tuberculosis, and its common symptoms are cough, chest pain, and coughing up blood. It can be treated. Next is Streptococcus pneumonia. It causes sinusitis, pneumonia, and meningitis, and more. It's a pneumococcal disease. It's a serious bacterial infection caused by Streptococcus pneumonia. Anyone can get it, but certain people are at risk. Best protection against the disease is vaccination. Next is Bacillus anthracis. It causes inhalation anthrax, and that can cause severe illness in both people and animals. The bacteria that causes anthrax occurs naturally in soil worldwide. Corneobacterium diphtheria. It causes diphtheria, which is a serious disease caused by a toxin produced by some strains of bacteria. Keeping up with vaccines is the best protection. The next one is Bordetella pertussis, which causes whooping cough, and it's a very contagious respiratory illness. Cough may begin like a common cold, but unlike a cold, the cough can last for weeks up to months. Next is Pseudomonas aeruginosa. It causes pneumonia, which is a bacteria and viruses are common causes of pneumonia. Clinicians aren't always able to find out which germ caused someone to get sick with pneumonia. Next is Legionella pneumophila. It causes legionellosis, which is water systems and devices can spread Legionella to people. The most common way for someone to get sick is by breathing in mist containing Legionella. Next is Chlamydophila pneumonia. It causes pneumonia again, which can cause respiratory tract infections. These infections are generally mild, but serious complications can develop. Next is Chlamydophila pistachii. It causes pneumonia again, which is just a disease caused by bacteria that often infects birds. People who have contact with pet birds and poultry are at increased risk for this. Mycoplasma pneumonia. It causes pneumonia again, and these infections are generally mild but sometimes can be severe. Most will recover with medicine, but some people need antibiotics to get better. Okay, moving on again to microbes that infect the respiratory tract. This time we're talking about fungi. So in this chart you can see fungi, type of fungi, and then the disease that it causes. All of these cause pneumonia, and pneumonia is just an infection of the lungs that can be caused by a variety of bacteria, fungi, viruses, and parasites. So the first one, Histoplasma capsulatum, causes pneumonia, like I said, which is a lung infection caused by breathing in spores of the fungus. Infection can be mild to severe and can lead to meningitis. The next one is Coccidioides imbetus, which causes pneumonia, also called valley fever. About 40% of cases of valley fever develop lung infection symptoms. Next is Cryptococcus species, which also causes pneumonia, a serious fungal infection caused by breathing in fungal spores in the environment. Most infections occur in people with weakened immune systems, particularly people with HIV or AIDS. Lastly is Blastomyces dermatitis. It causes pneumonia. An epidemic community-acquired pneumonia in some parts of the U.S. only causes symptoms in about 50% of people, but those with weakened immune systems can develop severe illness, including meningitis. And that is the summary of the respiratory tract and its infections.